Welcome to the next installment of the Many Minds podcast. Many Minds for better outcomes, encouraging collaborative community care for better outcomes. I'm Alex Davis, physician assistant, and I've got with me Tyler Murray, nurse practitioner. We're excited about today's episode, talking about intensive care.
And as a general disclaimer, this podcast represents the opinions of myself, Alex, and any guests that we have on our show, and are not intended to act as any type of professional medical advice, diagnosis, or treatment. We're just here to talk and have a good time. And with that, we'll jump into it. So we are privileged to have Diane with us today. She is an intensivist nurse practitioner, works for the hospital here at Mountain Point. And I think we just, for starters, just want to get to know you a little bit. Maybe have you give us your background and how you ended up in this specialty and kind of where you're currently at and what your day-to-day kind of looks like. So,
yeah, sure. Thanks for having me. I started out as a nurse when I was very young.
You're still young.
Thank you.
Yeah.
And I worked as a nurse for like 26 years. And then I decided to go back and get my nurse practitioner, and I did that. When I first graduated, I worked in a clinic for a couple of years. It was just kind of a family practice clinic. It was a little bit of a natural clinic, so we did a lot of natural, supplements and things like that. Kind of like before medication. It wasn't anti-medication, but just kind of supplements and best health. And I learned a lot. It was really quite, a good thing. And then eventually, after a couple of years, I decided to leave that, and I came to the hospital, and I'm happy to be back in a hospital, to be honest, because I've done so much of my career in hospital settings. So I initially started working here with our hospitalists, and I've been working here since 2015 when the hospital opened. And about in 2021, we actually hired an intensivist and kind of separated our ICU and our med surg section. And so I, at that time, crossed over and since then just strictly worked in the ICU with ICU doctors.
Oh, that's awesome.
So,
As a nurse, did you work what was your setting as a nurse? What was your history there?
I worked med surg for like the first 5 years. And then I actually moved from one hospital system to another. And so I actually decided I'll just go work in the floor. And I was in their PRN pool where you work where they need you. And I kind of thought, well, I'll just go see where I like at this new hospital. And I didn't like any of it. Or I liked this floor, but then I didn't like the nurses. The nurses, the med surg nurses, which is what I thought I would go to, they were like not very kind. And so I'm like, I don't want that. And I liked the fourth floor, but I didn't like orthopedics. And so one day I cut my finger on Christmas morning, and I went to the ER, and I'm like, maybe this is what I want to do. And so I applied and got a job. So I started working in the ER. Oh, and then I slowly transitioned from one ER, same hospital system, but over to a smaller hospital. I worked there for a number of years, and that was really fun. And then I decided to get off graveyards because I had done graveyards for 13 years. My kids were getting a little bigger.
Wow.
And so I literally applied for the first job that was like day shift. And It was an interventional radiology, which is really good, wonderful job. It was one of my favorite jobs ever. And I worked in there for a long time. So I worked a little ICU, interventional, and I did work
done it all.
Yeah, I did a little bit of ICU when in the pool, but I would not say I was really good at ICU. I didn't work there long enough to say, oh, I was really good. Because, it takes 2 years to say to be even competent as a nurse. Every time you change jobs, it takes like 2 years.
A while.
That's kind of the unwritten rule.
Yeah.
And so, and then when I came here, the good thing for me is that the hospital was brand new and it was very slow. And I worked.
You were able to grow with it.
Yes, and I worked with a doctor who was very mentoring, and I was able to really. So I wasn't like I was just thrown into the wolves of all these, and so I've just learned over time, and so I feel like it's been a really, but.
And if you could give a general definition to our listeners, just, the difference between a hospitalist and intensivist, like a hospitalist role, kind of what it is you're doing. Kind of in a simplified version.
And even maybe different from an internist or primary care, because you've been involved in those settings as well.
Yeah.
What's unique about your setting?
Yeah. So primary care, in clinic is, basically your patients are coming to you. You're doing overall care for them. Different age groups, anywhere from kids to adults, that kind of thing. And then the hospitalists are basically doctors. I still have to explain this to people because a lot of people say, what's a hospitalist? But hospitalists have only been around for, I'm guessing, 10 years or something, maybe a little longer. But They are basically doctors of the hospital. So basically, years ago, if you had pneumonia, your primary care doctor would admit you and treat you. And so all these doctors from all these different specialties were treating these patients, and someone figured out that it would be better to just have a doctor of the hospital so they could specialize. So now, instead of being like a primary care doctor trying to take care of this pneumonia patient and this pancreatitis patient and this blah 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 blah, they have doctors that are specialized in the hospital. And so I
didn't realize that's a newer kind of trend.
Mm-hmm. It hasn't been around very long. And in the world of medicine,
sure,
even 10 years isn't very long.
Sure. Yeah,
advances that's a long time, but not with generalized medicine.
Yeah. So it's still family medicine, primary care, what would be an internist, but just specific to the inpatients in the hospital.
Correct. So people say, "Oh, do you have a clinic?" We're like, "Nope, we do not have a clinic. We only take care of you while you're in the hospital. You go to your cardiologist, or you go to your primary care doctor, or if we're sending to a pulmonologist or whatever." And then, the hospitalists are very broadly trained in all the different things. But then we deal with pneumonia all the time. So we know, we need to do these antibiotics. Where if you are a primary care doctor and you admit 3 people with pneumonia a year, to keep up on that is hard.
Definitely.
And then the difference between like an intensivist is most of them are pulmonary doctors and critical care doctors, and they've trained in or they're internal medicine doctors. Mm-hmm. So internal medicine is just generally it's older patients. They're really
higher
complicated.
Acuity.
They are on 1 billion medicines, and they're just, so that's kind of, it's just it's actually a tougher field, in my opinion, than just a normal family practice.
And I'm always blown away at everybody's journey of how they get to where they go. And we recently did a previous recording with one of our guests was an RN, was a nurse, but ended up going to PA school. So we had a little bit of banter back and forth about the two specialties, and it's always fun to be.
I was trying to say how nurse practitioners,
But in this
why
setting,
would you go to a PA school if you're a nurse?
I don't understand it, actually. I'll tell you the truth.
Okay, I just isolated myself.
Yep. You set this one up.
But to show some appreciation for the nurse background in a hospital setting, if you're going to be a treating provider in a hospital setting, I can't think of a better background than nursing.
You're a lot more comfortable.
All the ins and outs of the hospital, because me having gone through PA school, that was the foreign environment to me, was the hospital setting.
That's true.
I was familiar with the outpatient clinics and a few of the different specialties, but the inpatient care was something different. So
you don't think about that. That's the same thing like when I first got my prescription authority and I could prescribe. For me, like giving my first opioid prescription wasn't really scary because I had given medications to patients in the hospital so much that I've watched their reaction. I knew the do's and don'ts, and I felt very comfortable. Whereas some of my peers might have been a little more nervous, like, "Hey, I don't think I should write this script." It's like, no, you can write the script. This is what we're supposed to do. So it's fascinating to see that difference.
There's a few, definitely some key differences between physician assistant and nurse practitioner. In your setting now, then, what would you say somebody maybe is not familiar in medicine themselves, but maybe not familiar with your setting and hasn't worked in the inpatient? What are some of the challenges you face? What are some of the difficult things, I guess, specifically for your patient population?
Yeah, so I work basically our hospital is a kind of a smaller hospital, so we do an ICU, and we also do like our step down ICU is kind of what we call it, whereas patients that just need to be watched a little bit closer, they're not really in ICU, but maybe they're on drips that need to be watched more closely, those kind of things. And then so for me, I just the ER calls, we have an admit. You go down and you see the patient and you take their history, and then I decide, and I work really closely with the doctor that's on with me. There's always a doctor that's on call with me too, and so I just kind of basically write all the orders. I just basically decide what antibiotics we need to put this patient on, what treatments do we need to do depending on how sick they are. I do a lot of the I do central lines and place, lines and dialysis catheters. I intubate patients. I will not say I've mastered like chest tubes yet, but I've done a good handful of them.
That's awesome.
But it's just all these
what
fun procedures. Procedures are always really fun. Most people like procedures.
I was going to say, I think in medicine, as many times as you can get your hands dirty, I think people enjoy doing that. It's definitely a cognitive type of profession. You got to be thinking about a lot of things, but anytime you can do some physical labor, it's a little bit more entertaining. What are the hardest procedures for you? What are the most difficult ones, or what are the ones you enjoy doing?
The most difficult one that I dread and I have not at all mastered this as like a bronchoscopy.
Oh.
Because, and this is what I've been told by so GI doctors do, kind of their scopes and things. So they're run the same, or if they're looking, whether they're looking down the GI system or in the lungs, which is a bronchoscopy, right? We're going down into the mouth, down into the lungs, and we're looking at the lungs. And I was told it's just like playing a video game. And I'm like, I don't play video games.
So you and I would be good at that.
Yeah, because it's just this eye-hand coordination movement thing. And then it's also knowing where you're at in there. And so, if the patient's actually intubated, which means they've got a tube, the breathing tube is in, it's a lot easier because you've already got it passed through everything, and so those are easier to do than if you're just doing it. And so those are my least favorite things to do. And what's funny is pulmonology doctors love them.
Sure,
they all love them. It's like their favorite. Oh yeah, let's go do this. They love it. And I'm like,
video games.
Let's dive in.
What about your favorite ones?
Probably the ones that central lines and dialysis catheters. My first dialysis catheter I ever did, I had done central lines before. I'd never done a dialysis catheter, and it's exactly the same procedure, other than it's just way bigger. And I was putting, my stuff in, and I didn't get enough gauze, honestly. And the kit comes with so much, and I've learned I always get an extra tub of gauze because they're bigger. And so I just made this mess everywhere, because I just wasn't. And so now my whole goal when I put in these lines, my goal is to get it in. That's all my goal. But I always try to hardly make a mess at all. I don't know why. It's just me, because I made just a big mess everywhere.
Was that patient awake? Were they able to see what was happening?
No, because they're covered with the full-on
they're draped and sterile.
And it wasn't like they lost tons and tons of blood, but it just was more than what I had ever done, because with a central line it's littler, and I just didn't make this. And all of a sudden I'm dilating this vessel up, and you take that dilator out, and all of a sudden it's like, oh my gosh. So I'm just, it was messy, and I'm like, okay, I got to get better at this then. So,
that's awesome. Is all of that in your scope of practice as a nurse practitioner, or what? I mean, somebody in that setting, or a peer or colleague of ours, what can they expect?
So that's the joy of
in that setting.
That's the joy of doing, in my opinion, and this is why I did family nurse practitioner, because they teach you in school. The main emphasis is women's health, pediatrics, and family practice.
Primary care,
Primary care. But when you get out, you can be trained, and PAs can do this
similar,
too. They just get trained to do whichever, if you go to labor and delivery PA, or if you're in infertility clinics, whatever clinic they just train you. So in this, they just train you. And there wasn't really a number that said, okay, you're competent after your 10th central line. There was a paper that I fill out every single year, and I write down or check all the things that I can do, and the doctor just signs it. And so one day when I felt confident enough to do it on my own without the doctor, that was in my mind when I was, okay, I can do this. I don't need him here. He doesn't. They don't need to. They don't come in for those things. For me, I just do them.
I love that.
So it's just training. They just watch you and help you. See one, do one, teach one. I don't think it's quite that easy, but
it's really not. I watched her throw in a central line, and she just made it look so easy. And I was actually shadowing you when I was in the nurse practitioner program, getting my clinical hours, and I was just impressed. So you just make it look easy. So you are there in many ways, but I can understand the thought. It takes more than once to really be competent in being able to do it, especially by yourself. So let's switch gears a little bit. I want to talk a little bit about work-life balance. So I want you to just talk about your work week, what that looks like, how many hours are you spending at work, what your schedule looks like, and what your, obviously your off time.
Yeah, when I first started working in the hospital with the hospitalists, so this is from 2015 to 2021, I had the cush shift of the world, and I didn't even know it. I worked Monday through Thursday, no call, nothing, 8 to 4. It was great. And I went to a conference one time, and I'm just chatting with all of the other hospitalists, doctors, and most of them are nocturnists, honestly, where the doctor works in the day and the nurse practitioners
covers the
or
night.
PA work at night. And I was talking to them, and I was mentioning that I worked day shifts, and I had this 8 to 4 shift, and all of them were going, what do you have? And I actually quit talking. I quit saying to anybody, because no one had the shift that I had. So I was so lucky. It was just great. And then since when I crossed over to the ICU, it's been a lot different. So I work. This is what I should be working. I was hired in this position to do 7 days on, 7 days off, and I was doing 5 nights of call on one of those weeks, and the other I do 4 nights of call. So I'm first call on those nights.
Oh, wow.
So my husband will tell you that I literally have 2 lives. I have my work life, and for a week, that's what I do.
It's bliss.
And then a week off. Because my week on, I'm still in charge of these patients. If I'm on call, especially, I'm in charge. I'm looking up labs. I'm looking up any tests we've done, making sure the nurses are still texting me. Sometimes all night long. Sometimes I've only had 3 times in over 3 years where I literally went to work, in the morning, worked all day, had a sick patient, was up all night, worked all day the next day. And by the end of it,
taxing.
I was just out. And luckily I wasn't on call that night. I'm just like, because my brain was gone. Like I was so, like 36 hours, I was so physically tired of on that. But luckily that's not the norm. The norm is more that I, get some texts. There's certain diagnoses that whenever I admit, I'm like, oh crap, I'm on call and I'm going to be doing labs every 2 hours. DKA, which is diabetic ketoacidosis.
Yes.
We're checking blood sugars every hour. We're doing
and you're
checking
reacting to it.
Yeah, and we're and there's protocols. The nurses are pretty good about knowing when to call and when to not. But we're drawing their blood every 4 hours, and I'm adjusting things every minimum of every 4 hours. So.
Wow.
Those kind of things. Sometimes with people with hyponatremia, when they come in and their sodium is really, really low, and we're checking again, we're totally just changing their fluids constantly, and I'll get a lab back because you can only raise their sodium levels, 4 to 6, or some documentation says 8 in the first 24 hours. So literally, sometimes I'm giving medicine to raise it, and I'm also getting medicine to stop it, so it makes it go slower up to try so you don't cause problems with the brain and swelling in the brain and things like that. So if I admit those, I'm just like, the first night I'm just like, it's going to be rough.
This is going to be a lot of hands-on.
I'm like, husband, go sleep in the other room because my phone is going to be going off all night.
But the week off is bliss.
And then the week off is just bliss. You do
nothing. You have no responsibility, no phone calls.
You can just turn off.
Nope. Yep. And when I'm not on call and I leave here on those 3 or 2 nights or whatever, those I just check off too. It's like, I'm out of here, dude.
I don't blame
and I
you.
just, you save all your things to do for those nights and stuff. And you're going to sleep. You're just like, okay, I know that I'm going to sleep this night. And so you just try to do whatever, just to go to bed and get sleep, turn off your phone so they don't accidentally call you when you're not on call, which happens a lot.
I bet. They know Diane.
Oh, sorry,
Diane
I looked at the wrong name. Sorry.
That's right.
Sorry, it's 2 a.m. I didn't mean to. I looked at the wrong name. Whoops. How about the transition back to going on your shift? You've had your week off. How do you approach that?
What's funny is when you have to do something, you just set your mind to it. Yeah. So it's really funny. So our other nurse practitioner quit in February. So since February, I've actually been not working my 7 on 7 off. I've been doing like 3 or 4 days every week. And we're hiring a new one. And so I'm getting myself mentally prepared to go back to 7 on. And honestly, part of me is like happy to have the week. I mean, a week off, you can go on trips, you can do projects.
True. Yeah.
Someone's calling me. Ignore. Anyways, and so just whatever. Got to get my brain.
It never stops. See,
this
is the prime example. It never stops.
That's okay.
Somebody always needs your attention.
I know.
If you're on, you're on.
Yeah.
By the way, little keynote for anybody watching or listening. She is currently on one of her shifts available. So we're grateful to have her here.
But what's funny is, so sometimes in the summer, whoever I'm working with, because we work there's 2 of us and we work opposite. So if I need a longer vacation, I will just work more or whatever. So there's a period of time where I will do literally 2 weeks on, 2 weeks off.
Oh, wow.
And the 2 weeks on, it's the same kind of thing. It's like you start work and you're just on for 2 weeks and your brain is set for that.
You kind of get into a rhythm.
Yeah. So normally you're on day 7. You're not like sitting here thinking, oh, I should all be off. You're knowing you're halfway done. And your brain just thinks, oh, I'm halfway done. Yay. Mm-hmm. And then towards the end of that second week is when you start thinking, oh, I only have 2 more days left. Yay. Yeah. And so,
cool. And then it's nice to have that flexibility though.
Yeah, it's
to
really
be able
nice
to change your schedule that way. Yeah. I love that.
Especially if you are with somebody who's has the ability to be flexible, so they can take, if I need 10 days off or whatever, I just work 3 days here, 3 days, and they'll work 3 for me, and then we just cover each other. It works really, really, really nice.
That's awesome. Yeah, that's really good.
Yeah.
Very cool.
And then 2 weeks off, you have time for a trip. You have time for projects. You have time, like you can. It's just amazing. When I just think this is what
You're happy with that balance, then it sounds
I think we should all work a week on, 2 weeks off. A week on, 2 weeks off.
I like that.
That would be the best schedule ever.
Yeah, that does sound fun.
And
well, maybe we'll have to propose that in our office.
Yeah.
See how that goes
I'm going
over.
to let you do that.
Okay, yeah, we'll see how that goes over.
Yeah, I'll follow your lead on that one.
Yeah.
Well, let's talk about, if we can, just a little bit about pay. You can get as detailed as you'd like, but just kind of want the audience to understand, listeners understand, do you feel like your work compared to your pay, is it compatible? Do you feel like you're paid well enough? Do you feel like you're in the top tier as far as salary? Are you salary or is it hourly? How do they compensate?
Well, we just got bought out a little over a year ago.
New ownership in the hospital.
In the hospital, and starting just barely in July, they changed how I'm paid. Mm-hmm. So I used to, for all the years working here, I kind of was just salary. And they literally said I had 4 weeks vacation. I would just kind of take off whenever I want. And the doctor would just have to cover. And
That's nice.
I just made sure I took my 4 weeks off, made sure I took my 4 weeks off.
Was use it or lose it, or what?
Yeah, it was basically kind of use it or lose it. And then, we started, as soon as the new company came, they started doing PTO, which I had never really had before. I had 4 weeks off, but paid. I mean, it was still kind of the same
you
thing.
Were salary, yeah.
But all of a sudden I have all this PTO, and then, but how do I use it? When literally there's 2 of us, and if I'm gone, he's working. And so eventually when this new company came, they actually paid us out our PTO, which was quite nice. But they paid it out because now that's gone. So now I don't have PTO anymore. And I get paid if I work, and I don't get paid if I don't work. So that, we just try. That's why, and it's pretty fair because I don't, so if I just take off or I'll just try to work extra shifts or just make sure if I take off the extra time, I just work extra for him. And so or him or her, whoever.
Do you think people that are interested in a hospitalist, intensivist setting, like, compensation-wise, across advanced practitioners, do you feel like it's pretty competitive?
I think it's pretty competitive. I do. I feel like it's at the higher end, and I feel like no one ever thinks they get paid enough, right? Do we ever really feel like we?
That's fair.
But I do feel like if I were to try to change to another job, I would think I would probably have to take a pay cut unless I really found a specialty that really, because I feel like just knowing what other jobs, if you ever look at jobs and you can see what the pay range is, I feel like I'm at the higher end.
Which I think should be that way, because listening to your history and your work experience, it's not just anybody that can just jump into that position. You need somebody that's got legitimate experience and knows what they're doing to handle that type of patient population.
And sometimes it's hard. Sometimes I'm thinking, and why did I quit and leave my wonderful interventional radiology job?
Yeah.
So wonderful. Why did I quit that to go work so hard?
So many responsibilities.
And so be busy, and sometimes it's stressful.
Is there, so we work for an independent practice as far as hospital setting. Is there a ladder? Is there a ceiling, like where they tell you at some point you're going to reach a maximum amount of money that you can earn, and it'll only be based off of inflation, or what does that look like?
I think for us, literally, they have 2 tiers. They have, if you've worked less than 3 years, you get X amount. And if you worked greater than 3 years as a nurse practitioner, you make this much. And I think our only raises are if they do like cost of living raises, and they just decide to make an adjustment. Okay. Which, I think they will. There might be a percent. I just can't remember. I'd have to go back and look at my contract. I can't remember. But I think there's like some kind of a cost of living. But is that adequate? No, probably not.
Okay. Not for any of us.
Not right now.
Yeah, not right now.
When everything costs so much.
100%. Yeah. I'm with you there.
Well, how about something fun in your setting? You got any kind of memorable patient experience? Because everybody's setting's a little bit different, and in your setting, probably a bit unique with inpatients. What's a fun or memorable patient experience you can share with us?
I don't really have. I have tons of stories that I like.
I'm sure.
Can or cannot share.
Cannot share. I have tons of stories. I'll just say that in my field, what I like the most is I love to see how incredible our bodies are, how incredible we have the ability to heal. You get people that are so sick, and I mean, and the majority of the time you watch, and they can get better, and they survive, and then, you know, it's just, it's so intricate. It's so cool to see how the heart and the lungs and the kidneys especially, and the liver too, but how tied together they are. So if this is out of balance, then you got to fix this, and it's, I don't know, it's just so, to me, that's what I like. And every patient's a puzzle. That's exactly how I look at it. People come in and they're presenting with these symptoms, and it's literally a puzzle to figure out what is it, you know. And some people have more than one thing going on at the same time, and that just plays into the puzzle and stuff. So to me, I don't know if I've had tons of experiences, and some are great, but I just think it's cool to see people.
It's the collective. It's the collective memory.
And you watch people just hopefully, you know, get better. And then I've of course seen the other side where this is what I call it. I help people to heaven quite a lot, where we do kind of comfort measures and stuff like that.
That's the reality of it, though.
That is the reality of it.
In some cases.
Yeah. And that can get hard too, and stuff, but you kind of learn how to.
Yeah, you probably do see a fair amount of that.
Yeah. You know, and my dad kind of did the same thing in a hospital, and so it helped me, actually. I feel like, you know, there's always, you have something happen to you in your life that helps you, and you're like, wow, I think I experienced that, and that is helping me do this.
Yeah, sure.
You know, but
there's a level of, you have to be compassionate, but you also have to not let it affect you.
You got to be the objective one in that scenario. Yeah, because there's enough emotion, I'm sure, with the patients and their families as well. So you've got to be the one that's a little bit more objective in things.
And you also learn that every family is different, and families take time sometimes to come to understanding of what's happening, and sometimes in my mind I know this is going to go this way, and I know this is what's happening, but the family's not there yet, and so it's just time. You got to let them get there with whatever direction it's going, and things like that. So
that's interesting.
We shared a patient. We had one of our patients we operated on that came through your guys' service, and we were consulted, and he had a spinal epidural abscess and was septic, and he was very sick. He was in bad shape and did not look good, and we performed the surgery and evacuated the abscess. And then I remember, because I was the one that went and saw him in the inpatient setting, and then I got to see him at his follow-up visit in the clinic, and I would not have even known that was the same person. Crazy. It is miraculous, alluding to what you're talking about, how people can heal. People can get quite a bit better, and
our bodies are
just
amazing they're meant to heal itself, and sometimes a little bit of help, you know, with antibiotics and surgeries and things like that. But if you give it that, our bodies most of the time will heal on their hill, and it's cool to watch. I never get to see people after, hardly ever. Every now and again we have a patient comes back to the ICU, and you're like, wow. So we have a couple of COVID patients that survived, and every now and again they'll come back, and you're just like, oh wow.
Well, we hope that we don't have any of our patients on your service line, but if we do, we'll keep you informed how they're doing in the outpatient side of things.
Yeah,
so
that's great.
Of course.
We love to
see in your setting, this is also kind of a bit unique one, but we like to ask everybody, what's trending, or what's new and innovative, or what are you guys looking forward to changing and improving in the world of intensive care?
So again, our hospital's kind of smaller, and so there's some cardiac things that we're trying to really start teaching, and I mean, just not teaching, but I mean getting our nurses up to par, like the Impala device. So there's technologies that big hospitals are already doing all day long, but we are just kind of stepping into that.
What is the Impala device?
So it's a device that you put in when someone has left ventricle heart failure.
Okay.
That there's a pump that you put in the ventricle, and it will literally pump blood from the ventricle out into the body.
Wow.
So it buys them time while their left ventricle is healing if their left ventricle's failing. So
that's amazing. I didn't know that.
Yeah. So it's pretty cool, and our hospital is all gung-ho about it, and we're like, let's learn how to do this.
So learn how to do it and
they've
manage
had reps
it,
come, and we've only had a few, and I would not say we're, you know, but we're getting
making
much better.
steps. So
at this point, we place them. Not, you know, the cardiologist will place them. At this point, if they're really stable, we might keep them. But if not, we then transfer them to a bigger hospital, which is the appropriate thing to do. But we're hoping to just, you know, get better and better and better with those things. And then the neurology is in. You know, we're just kind of starting to take a few neurology things like subdural bleeds, where we just kind of watch. They're usually really stable, but we used to ship all of those out, even those stable ones, when in neurology, the Dr. Edwards is looking at it going, I know this is going to be fine, but we'd have to ship those out because we didn't. So we've started taking some of those patients. We've done a couple brain surgery kind of things that, and so we're just kind of stepping over, crossing into some of those, taking, bigger cases or more specialized cases, I guess is what you want to call it.
Very cool.
And it's been pretty unique to see the hospital grow in that way. I mean, I remember when it was first built and started, it was one hospital organization, and now it's a different one, obviously, but it's been unique to see the growth. And I think Dr. Edwards has had a lot of confidence in the hospital's ability. So I think you just see that, like you were saying, it's not always, see one, do one, teach one. Sometimes it takes a couple of doing and trial, but you have to try. And so I think it's great the hospital's doing that. And obviously they have a great supporting staff that can help them facilitate those changes. So it's awesome.
Thank you.
Yeah,
Thank you.
that's great. Well, we should wrap it up. Diane, we appreciate you coming. This has been fantastic. I've learned a bunch. Tyler, what do you think? What have you learned?
Well, first of all, I'm in awe, Diane, because you have a vast amount of knowledge and skill set. Like, I feel like I'm so dialed in with neurosurgery, but if you were asking me to do anything outside of that, I'd be lost. And I feel like you're the type of person to be like, yeah, I got this, I'll figure it out. So I really am inspired by it. I think it's awesome. I love that you broke down the hospitalist versus intensivist kind of specialty. And just a really unique setting, 7 on, 7 off. Sounds like pretty good pay. So I feel like you're in a good spot. And for those that are interested in it, obviously maybe they can reach out to you and get some more information about what your world looks like. And maybe we'll ask how you go about doing that.
If someone were to want to reach out and learn more about what you do, ask some questions or follow up, how would somebody reach you or get a hold of you?
They would probably have to call the hospital.
I love that answer. Yeah.
Yes.
So, someone was trying to find me the other day, and they finally found me in my office and said, I have been looking all over this hospital for you. And I'm just like, well, most people know who I am. I've been in this hospital for a long time, so I know I know a lot of people, and I was surprised they said it took very long to find me because anyways. So
you're not on social media. You don't want us blasting your social.
No.
Okay, fair enough.
Yep. Well, you can come down. She's with the Common Spirit Group, Holy Cross Mountain Point Hospital in the ICU is where you can find Diane. Our group, Tyler and I are with Summit Brain, Spine, and Orthopedics. You can find us on Instagram, Summit Brain, Spine, and Orthopedics. Our YouTube channel is the Summit Medical Institute. And always, we'll see you Tuesday mornings here in person at the Mountain Point Hospital in Lehigh, our 7 a.m. Tuesday morning multidisciplinary case study rounds. We appreciate, shout out to our production team, huge help on the back end of things. And we look forward to the upcoming episodes.
Stay tuned.
We'll see you next time.
All right. Thank you.